Hello, my name is Dr. Manuel Cerquera at the Cleveland Clinic, where I'm chairman of nuclear medicine and a staff cardiologist, and I'm joined here today by my colleague.
Hi, I'm Aldo Escanone. I'm one of the current fellows at the Cleveland Clinic.
And we're going to be talking about technical issues, differentiating between ischemic memory and cardiac sarcoid using PET imaging. And Aldo, if you present the first case.
Absolutely. It will be my pleasure to present this case. So this was a 61-year-old woman who has a history of proven sarcoid that was involved in the lung and the brain, for which she received steroids and immunosuppressive therapy. However, she comes back and complains of ongoing weakness, shortness of breath, and cough. And more recently, she experienced an episode of syncope with ongoing palpitation, at which point there was concern for cardiac sarcoid in this patient. Therefore, patient was referred for whole body and cardiac PET scans for the identification or screening of cardiac sarcoid. However, given the patient's age, risk factors for CAD, and the absence of prior testing for coronary artery disease, and given that syncope can be a presentation of ischemic heart, stress perfusion images were also requested at the same time. So the patient underwent resting electrocardiogram, which essentially we see here is a normal sinus rhythm, and essentially normal. I think this contrast to what we usually expect to see in patients with active cardiac sarcoid, in which we see conduction abnormalities such as AV block of any of the flavors. We see bundle branch blocks, and we can even see the presence of high burden of PVCs, which we don't see in this patient.
But the presence of those findings or the absence neither confirms nor negates the presence of cardiac sarcoid.
That's absolutely right. So as we mentioned, the patient was referred for both myocardial perfusion studies and FVG sarcoid study with PET imaging. And in this slide, we outlined the protocol that we follow in our institution. The patient received regadenoson as a stress agent, after which she denied any symptoms, and there were no ECG changes to comment on. The patient was prepped with a 14-hour fasting devoid of sugars and carbohydrate, which is current recommendation for sarcoid protocol, in order to minimize glucose utilization in the myocardium. That way, any FDG that we can detect reflect the presence of inflammation in the heart.
So for some of our audience that doesn't do cardiac sarcoid, or many don't even do hibernation evaluation, why is it important to avoid these compounds?
So you mean the sugars and the carbohydrate?
Yes.
Yeah. So as we recall, the heart utilize glucose and free fatty acids. It's predominantly a fatty acid metabolism, but there's some glucose. So when you're doing this study, you are trying to switch the metabolism of the myocardium completely towards fatty acids. And the way you do is you just basically devoid the heart from glucose with this fasting and avoiding these sugars and carbohydrates for a period of time. So that way, when you image the patient with FDG, which is basically a modified glucose, the heart doesn't pick that agent, and if only the inflammatory cells pick that, so you can actually identify the inflammatory response from sarcoid.
So the heart tends not to use a lot of glucose, but it does use it. And unlike hibernation, we're trying to get the heart to take up the FDG because
Correct.
There's enough blood flow. Here, we're trying to minimize it, and certainly avoiding high sugar by fasting people, by having them not eating sugar or carbohydrates. And some places would actually give a fatty meal where
Correct.
you get them to eat a lot of protein. Now, what else can you do that may optimize the lack of glucose utilization?
Yeah, one thing that people have studied is the use of heparin before the study, and the rationale behind that is that heparin might increase the free fatty acid liberation into the blood pool, allowing the heart to utilize fatty acid rather than glucose.
And so you would basically give the people 15 minutes before you give them the FDG. You would give them like 5,000 to 7,000 units of heparin, and that causes the liver to turn out a lot of fatty acids. So you basically overwhelm the glucose that's there, and you suppress the normal myocardial uptake. Absolutely. So very good. Continue.
So this is this is how the patient was prepped in preparation for the Sarcoid study, and you can see that the glucose was kind of under good control there, and FDG Sarcoid images were also obtained in addition to the myocardial perfusion, as we commented already. So here we have the images of both the myocardial perfusion and also the Sarcoid study. The first thing, at the top panel, we see the images during stress, followed by the images during at rest. And at the bottom, we see that the images, the FDG images. In the lower part of the slide, we see the polar maps, which basically make it easier for the interpretation of the findings. I think the first thing that I want to point out your attention to is if you go down here to the FDG image, we see that in that apical septum segment, there is evidence of FDG uptake, and you can see it again here in these images here, the long axis view. So, which raises the question: is this active sarcoid or not? However, when you interpret that in the context of a perfusion study, we can see that in the same exact area, in the apical septum area, there's evidence of a reversible perfusion defect consistent with ischemia. And again, we see in the horizontal axis here too in the images. And again, that raises the suspicion that what we're seeing here in terms of FDG uptake represent probably the ischemic memory phenomenon rather than active sarcoid. So, but I think you need to use the whole spectrum of the result that you get from the step to kind of actually get to the conclusion of if this represents ischemia, ischemic memory, or this represents active sarcoid. So the next set of images that we see here are the gated images for this study, and as you can see, in general, we can tell that there is a good function with. I don't think there is any significant evidence that there is any wall motion abnormality. Maybe perhaps in that apical septal segment, we can see also that the ejection fraction is 61% at rest, and it doesn't decrease, and it just stays the same with stress, and it has a normal end-systolic volume in these gated images. Again, you still have the question: how much of this FDG that you're seeing is a switch in the metabolism of the myocardium as a result of ischemia, given that the perfusion effect overlaps with FDG, or how much this represents active sarcoid with the addition of ischemia. So I think you need to maximize the information that you can gather with PET, and some of and the PET provides you with CT images that you can actually go and review, and as we did in this case, and where we identify the presence of coronary calcification, which support the diagnosis of coronary artery disease, and again add more evidence towards the theory that this is probably ischemia in that segment with ischemic memory explaining the FDG uptake.
So when you do PET, you do usually CT attenuation correction, and you get, these are not diagnostic CT images, but you can certainly see calcium, and people have quantitated this as well. So it's additional information.
Yeah. So the patient also went for a whole body PET study as part of the Sarcoid protocol. I think the first thing that we need to say is that there's this great of discussion between just doing cardiac PET images without the whole body images. But I think if we're able to have that information, I think it's useful in terms of guiding management and this patient, and as we're going to see in this case. For instance, when you focus on the areas first in the heart that lights up with FCG, we can see that the only area that we're getting that uptake is right there at the apex, in the area that we already identify an area of reversible perfusion defect. But more importantly, we can see that there's no other area in the heart that lights up, and there's no any other area in the chest, nor the lymph nodes, nor the lung are lighting up for FCG. And we don't show the images here, but at the moment of diagnosis for this patient, the patient had a significant uptake of FCG in the nodes and in the lung. And after treatment, we can see that there was an interval resolution of these findings in this study. So when you put things together, you see that the only area is in that area of reversible defect. You have no other FCG uptake elsewhere. And then you have complete resolution of the foci or FCG uptake that you had before. It makes it really hard to say that this represents active sarcoid and falls within the theory of ischemic memory in this patient.
So we make some assumptions that 1 year of effective treatment that eliminated all the lung nodes and the hilar adenopathy has also has been effective. And so even though we can't definitively exclude that one area being due to sarcoid, the fact that it's in the area of ischemia, so-called ischemic memory with FDG uptake, certainly is suggestive that the patient's syncope was due to something else other than cardiac sarcoid involvement.
So, that's exactly how the study was read. Given all the findings that we already discussed, these findings were likely to be related to LAD ischemia in that apical septal segment with ischemic memory explaining that FDG uptake rather than inflammation from cardiac sarcoid. So the patient was followed up in clinic and a cardiac MRI was obtained to actually put to rest this concern, and there was no evidence of cardiac sarcoid on cardiac MRI imaging of the heart. So given that the patient was in not having any chest or angina chest pain, and based on the narrative of this syncopal episode was kind of not consistent with what we would see with a cardiac syncope, in addition to that the perfusion defect was really small, I think the decision at the end was to treat this coronary artery disease medically and follow up the patient clinic.
I think one important point here is that this patient is unique for some of the others that we see here evaluating for sarcoid, because she doesn't have a pacemaker and she doesn't have a defibrillator, which we very frequently see. In those patients, you can't do an MRI, and PET may be one of the only ways that you can diagnose these people. So here we are to the question. So I'll read the question and then you can go through the answers. Question number 1: which of the following indication for cardiac PET for a sarcoid study is false?
Okay, so we're going to go over one by one and just try to see which is the right answer here. So the option A is the patient with biopsy-proven extracardiac sarcoid who comes with syncope. I think in this scenario, it's really concerning the presence of syncope in this patient, which is one of the symptoms of cardiac involvement. And I think you should and you need to screen for cardiac sarcoid. And I think in this scenario, PET would be, well indicated.
And again, some of the indications are that if you suspect cardiac sarcoid, a myocardial biopsy may not be the best way to do it. And if you want to confirm sarcoid, you go for the extra cardiac tissue first, and then a study like this or an MRI could be further proof as opposed to doing that primary biopsy.
Absolutely. So if we move to option B, those patients younger than 60 years old with unexplained high degree of AV block, I think we already discussed a little bit on this. One of the most common findings in these patients is the presence of conduction abnormalities. So in a patient that is young, who has an unexplained high degree, I would be really concerned about the presence of cardiac sarcoid. In the right clinical scenario, I think in this type of patient, I think a PET would be of help, especially given that we know now from evidence that usually these AV blocks and conduction abnormalities usually occur during the inflammatory phase of sarcoid, and PET is ideal to detecting that active inflammation.
Good. C?
So in patients with biopsy proven cardiac sarcoid, would you do a PET? I think there's two reasons why we do a PET. One is to secure the diagnosis of cardiac sarcoid, as we're probably doing for the prior two patients that were in these questions. But the second indication for PET is just once you have the diagnosis secure, I think you want to know what the response to treatment is. And I think having a baseline PET, identifying the degree of inflammation and how the patient is responding to treatment, I think is key for this patient. And we saw a little bit of in this case in which naturally it was in the heart, but we saw that the patient who initially had a lot of FDG uptake in extracardiac tissue then resolved with the use of immunosuppressive therapy. This is something else that we can use for cardiac sarcoid.
Good points. And the correct answer is D.
Yeah, so in any patient that who has extracardiac sarcoid but has a normal ECG, a normal electrocardiogram, I think the yield of PET is pretty low. I think in those patients, what is usually recommended is close follow-up. I think there's always will be the concern for extension and involvement of the heart, even though if an initial presentation doesn't have any suggestion of. But I think at that point, I wouldn't necessarily jump into cardiac PET.
Good. All right. So we go on to the next question. Question 2. Which of the following regarding a cardiac PET sarcoid study is true?
So option A, prolonged fasting is not required. And we already talked a little bit about this. I think in contrast to perfusion studies when you're trying to maximize actually glucose utilization, viability studies, right, maximize glucose utilization. In sarcoid study, you're trying to do the opposite. You're trying to minimize glucose utilization in the myocardium, so that way any glucose that is uptake in the FDG study is picked up by the inflammatory cells during active inflammation. So I think prolonged fasting is one of the most effective strategies that you can do to actually optimize the PET sarcoid study. There are some other strategies that you can do, like the addition of a high fatty meal, and as well as the use of heparin, as we touched upon a little bit in the presentation. So prolonged fasting is required.
But this is an important point because when you're trying to look for sarcoid in the myocardium, you really need to suppress the normal uptake. Otherwise, if you get sort of diffuse myocardial uptake, you can't tell whether it's a negative study or somewhere in there are areas of inflammation. So preparation is very, very important. And to us, the ideal study is you basically just have persistent blood pool. Everything is in the cavity of the ventricle of the FDG, and there's nothing in the wall. Then you're pretty sure that that's a negative study. So B?
So excluding significant coronary artery disease is important since obstructive CAD can also be a source of abnormal resting perfusion and FDG uptake. And I think this case illustrates that pretty well. I think the FDG uptake is not pathognomonic of sarcoid. I think you can have FDG uptake for many reasons, including poor preparation for the sarcoid study, but especially in patients with a significant or obstructive CAD in which the ischemia drives the ischemic memory phenomenon in which the myocardium turns the metabolism into glucose, you can have this FDG uptake and confound the results of the study. So I think excluding or having an idea in terms of obstructive CAD in this patient is important, since FDG uptake can be, confusion in this patient between this is ischemia and this is sarcoid. And you have to use, when you are in presence of that challenge, use all the information that you have available within your study, as we did with the CT images, with the whole body PET, improvement in treatment. If you have that information to actually come up with an educated conclusion in terms of the FDG. So this is the right answer.
Very good. And C?
So a simultaneous PET stress and Sarcoid study can accurately discriminate between ischemia and active sarcoid. And I think we already discussed this. I think it's really hard to know for sure if this area represents ischemic memory or this area represents sarcoid. And you have to use all the information that you have available. So this is a false statement. It's not, you cannot accurately discriminate between those two. In option D, the presence of resting perfusion defect or increased patchy FTG uptake has no prognostic implication in the setting of cardiac sarcoid, and this is false. When you have sarcoid, cardiac sarcoid, the first thing that you see is this patchy FTG uptake, which represents active inflammation, and that active inflammation can disrupt coronary flow, and eventually will lead to fibrosis and granuloma formation and occlusion of these vessels in which you have resting perfusion defects. So the presence of either or the combination of perfusion defect and FTG has significant prognostic implication with poor prognosis to the patient.
Very good, very good. So those are all very important points. And so the teaching points, do you want to go over them?
Yeah, so I think let's start with the indication. I think any patient with sarcoid that is involving extra cardiac structures who has unexplained palpitation or syncope is highly concerned for sarcoid, and you should pursue a PET sarcoid study. It is important that to increase the yield and the interpretive accuracy of the testing, you should have a really well preparation prior to the testing. And some of the things that we like to do, and then there's evidence supporting that, is a prolonged fasting with perhaps prior to that some high-fat meal who provides a lot of free fatty acid for the myocardium. And the use of IV heparin just before the images in order to really minimize glucose utilization in the myocardium and allow to only detect FTG uptake in the setting of active inflammation from sarcoid. So as we talked before, so what's the ideal test is in terms of the ideal image in those patients with sarcoid is that those that we have really good amount of blood pool without any uptake in the myocardium, which would rule out the presence of sarcoid. But in the other end of the spectrum, what's a positive PET study for sarcoid is usually that what we call focal and diffuse. You have this kind of patchy confluence of FTG uptake on a diffuse background, which basically represents the presence of inflammation. And this can be associated with the presence of a perfusion defect at rest. And again, this is on a spectrum. You can start with inflammation initially. You have only FTG uptake, and then you progress to the presence of FTG with inflammation and perfusion defect, suggesting there's some disruption of the coronary flow. And eventually you can even get to the phase when the inflammation is no longer present and you have no FTG, but you have this persistent perfusion defect.
So it's a spectrum of disease over time, and it's also, it can be very focal. I mean, you think of systemic diseases as being diffuse, involving a whole organ, but the reality is it can be very localized. Sometimes the RV can be involved over the LV. We've seen a few cases where you can actually get atrial uptake. So very good points in terms of the patterns. Next point.
So next point talks about stress-induced ischemia that might result in ischemic memory and enhanced FTG. That's exactly what the case illustrates. I think that FTG is not just uptake is not pathotomonic to sarcoid, and there are other situations which you can have increased FTG uptake. You need to be cognizant of those. I think if you're doing a concomitant perfusion study and a sarcoid study, you need to be aware that the presence of ischemia can trigger the ischemic memory phenomenon with the increase in FTG uptake, and that can confuse the interpretation of a sarcoid study. And again, you have to use as much information you have available to come to the conclusion of what.
But ideally, you'd like to have, and many of our patients, when they come to us, either through the heart failure clinic or through the arrhythmia clinic, they've already had caths done. So in that situation, I'm not sure you need to necessarily do the stress portion because it may confuse the diagnosis of sarcoid. More of a problem in people with known disease who've had infarcts, who have grafts. And in that situation, you may want to do it, but ideally, if you could just do a true resting study without inducing ischemia and then do the FDG, then I think you'll get a cleaner answer. And the next point?
I think you touched on that a little bit. I think, in the ideal scenario, you would just do resting and FDG, focusing only on the sarcoid perspective, and try to address the ischemia component, either, doing a coronary angiogram or doing a different testing, or in different sessions. And finally, the presence of resting cardiac perfusion and or FDG uptake it has, of course, therapeutic implication and prognostic implication. So the presence of FDG uptake, suggests the presence of inflammation, in which probably immunosuppressive medication would be indicated just to suppress that. Conversely, you have a patient who has no FDG uptake, but you have significant perfusion defect at rest. That's a patient that has more like a fibrotic phase, and the benefit of immunosuppressant therapy at that point might be questionable in terms of how much you can gain by doing it. That from a therapeutic standpoint. From a prognostic standpoint, clearly the outcomes of patients who had either or of these findings is worse than those who has none of them.
Very good. So, cardiac PET sarcoid studies in the right clinical context with the right preparation can give you very useful information for diagnosis as well as management. And we're starting to see a lot more people who don't tolerate the steroids very well, where they need to add additional immunosuppressive therapies that may give other problems. They're using the PET study to sort of monitor them. Well, thank you very much, Aldo, for doing such a great job.